Our next speaker is going to be Professor Graham Hughes again. He's going to speak on B-cell depletion and lupus.
Part of the morning. So this is, yes, it's rituximab, but it's also a general view of lupus. And I hope some of the things will come out in the questions. This is, again, data from our center in London, but it's from a number of centers, David Eisenberg's and a few others, and I will quote them. But I'd like to call this failure and success. And I think Joan has already mentioned some of the failures, certainly the design of trials, and some of the failures in our clinical practice. This was my first teacher in rheumatology, Michael Mason. He was a great clinical rheumatologist at the London Hospital, where I was a junior doctor. And he edited a book called Mason and Curry, Introduction to Clinical Rheumatology, which we all sat round the table, I remember, and each one of the gang was asked to write a chapter. And being the youngest in the department, I was asked to write the chapter on lupus, which I knew nothing about. So this was my introduction back in the mid-60s to systemic lupus, and I'll just come back to that in about 15 minutes. I was fortunate enough to win a scholarship to New York, where I worked with the great Chuck Christian, who I absolutely idolize. He was the greatest leader that I have ever worked with. My wife and I, and one child at that time, in 1969, were there living in New Jersey, watching the actual building of the Twin Towers. It was, for me, a very exciting time because we were involved in the introduction of the FAR technique for anti-DNA antibodies, together with Ted Pincus, Rob Lightfoot, Peter Shaw, and of course, Chuck Christian. This shows the very amateurs, one of my first attempts as Octoloni, but the excitement for a young fellow coming from a very clinical background to actually dirty his hands in the lab can only be believed in practice. And these were simple Octoloni plates showing two serums, one reacting with native DNA and denatured, and the other with denatured DNA alone. But it is interesting how the FAR technique and DNA antibodies has stood the test of time. And in fact, DNA antibodies is one of the most specific tests, if you think about it, in the whole of medicine. Certainly more specific than, say, uric acid for gout. What is lupus? Well, we all know that this is very unusual. I mean, we see 5 or 6 classic butterfly rashes in Britain in a year, probably because of our climate. I'm sure you see many more here, but the classic view of lupus of a young woman with renal failure and a butterfly rash is, of course, very much outdated. This is a group of patients attending the Heberden Round. This is an annual meeting of the British Society of Rheumatology where one British rheumatologist presents his or her special interest. And this was 1982, where I had the honor of presenting them, and I, of course, talked about lupus. And these are all young women with various forms of lupus. I haven't got a pointer. Joan's stolen it. Thank you. Each of these patients has a different story to tell. And it just, in a clinical way, epitomizes the heterogeneity which you've been talking about. This young girl had severe Sika syndrome and a deforming arthritis. This girl had shrinking lungs, elevation of the diaphragms, and her sister had ITP. And 3 of these girls are very interesting. This particular lady had migraine and thrombocytopenia and was our first presentation in public of the Antiphospholipid Syndrome. And this girl, Cushingoid, had had bilateral renal vein thrombosis and was another patient with Antiphospholipid Syndrome. This lady, I want you to remember her face because I'm going to show it again in a minute. But this young girl had discoid lupus, DNA negative, and was found wandering around London emptying garbage cans and was quite psychotic. Discoid only, ANA, DNA negative, but now normal. So this was a presentation with cerebral features, and at that time, we, like others, were looking at lymphocytotoxic antibodies, which we thought might cross-react with brain. It was very soft sort of data, but she was positive for anti-lymphocytotoxic antibodies. So the different faces of lupus with different lessons. Now here, is another of these non-specific clinical criteria. I'm an anti, Joan's anti the sort of trial brigade, and I'm anti the classification criteria. I would say look at these, or teach your students to look for these. We've talked about childhood migraine. In the United Kingdom, they're often called growing pains. Teenage glandular fever, so common in the history of both Sjögren's and lupus. Phobias of every sort, particularly claustrophobia, agoraphobia. Septrin we don't see anymore, but if you look at primary Sjögren's, Rho-positive Sjögren's particularly, very allergic. And in many of our lupus patients 30 years ago who were given a sulfur-containing drug such as Septrin, sulfonamides, had severe Stevens-Johnson. You heard about some of that in one of the questions this morning. Fibromyalgia and all those terrible things, often the label that these patients are given. Intermittent alopecia, of course. And one thing that it's hit me over the years, and I'd love to have feedback, this is very soft, but lupus patients don't get the same frequency of colds and flu. Everyone in my family, doctor, went down with the cold that was going around this year, and I seem to be immune. And we've looked at that in a very soft way and found that to be extremely true. And I think for the immunologist, if it is true, it's of some importance. Well, we all know that lupus has exploded. This was a map of when I was in a training lab with Chuck Christian in New York. This was the world map of lupus. These were centers that had published 200 cases or more. And there was East Coast, West Coast of the States, hotspots in the Caribbean, London. There was a large clinic, but it was only 200 patients. But the world map was empty. No lupus in Australia, none in the far, well, very little in the Far East, none in Africa, none in South America. Well, this has changed out of all recognition. This is already out of date, but these now centers everywhere. And in some areas, as you know, particularly the Far East, it has overtaken rheumatoid in prevalence. Certainly in Indonesia, in Malaya, Singapore, it is common. Still the mystery remains as to whether lupus is genuinely less common in Africa in view of its frequency in Afro-Americans and in the Caribbean. We're certainly seeing lupus now coming from Africa. We did a study in London asking the question, is lupus different in Afro-Caribbeans from Africa or in, Africans from Africa or in the Caribbean? And there's one place in the world where large numbers of West Indians live side by side with West Africans, and that is Lambeth, right behind St. Thomas's. So we did a study there, and what we found was that the Africans who'd moved after the second generation, lupus started to increase in frequency. Now, again, I'm not an epidemiologist, but I gather there are theoretical reasons that that might be so. So, failure, success, and into the unknown. Let me start with some examples of failure. I suppose many people wouldn't show this, but Jacques arthritis is a failure. You all know that if you have a patient with bad chronic tendon problems, bilateral Achilles rupture, or severe flexion, there's very little you can do about it. These patients just go on and get worse. And we are extremely helpless faced with that treatment scenario. How on earth do we treat these patients? Here's failure. This is the extreme end of discoid lupus. And I think many of us would, if we're asked for our worst 5 patients, I don't know if Joan comment on this, but I think skin comes into the top 5, 4 out of the 5 perhaps, of severe, and that's why drugs such as Mofetil are being tried in severe discoid lupus. But when it's bad, it's very bad and poorly responsive. Here's a failure. This actually is the Antiphospholipid Syndrome. This woman got infarction of the skin of the nose, the ears, and the cheeks. She had antiphospholipid positive and sudden, almost an early catastrophic picture of skin infarction. A failure so far. Sticky blood. I've showed this morning examples of failure as well as success. And here's another failure. This very benign disease, not shown very well here, but subacute cutaneous lupus, the tragedy of congenital heart block. Failure. Once a woman's had congenital heart block, or once the baby's heart block goes slow, so far, no data should show improvement. And I'll come back to that. And finally, here's, of course, our backpacker from Australia who died of a heart attack. We know that another failure of lupus is the long-term failure.